ve sen olarak altın sponsorluk ödülü. Gerçekten her zaman yanımızda büyük bir güçle durdular. Bütün ekibe teşekkür ediyorum. Menarini Grup, onun adına Aslı Hanım'ı buraya davet ediyorum. Evet arkadaşlar, şimdi günün en anlamlı anına geleceğiz ama ondan önce biz bu altın acil ödüllerini 7 yıldır veriyoruz ve çok değerli, şu ana kadar gerçekten çok değerli bilim insanlarına bu ödülleri verdik. Bakın, bu Gazi Yaşargil 2015'te ilk ödülü alan, şu anda da Milenyumun 100 yılın cerrahı, 100 yılın cerrahı, beyin cerrahisinde Türkiye'mizin gururu. Sonra Aziz Sancar'a verdik. Nobel'den sonra biz ona ödül verdik. Bakın neredeyiz yani. Nobel ödülü alıyor, sonra gelip bizden ödül alıyor. Ve ikinci defa altın madalyayı Aziz Sancar'a verdik. Üçüncü ödülü yine Amerika'ya gitti. Goldfrank, biliyorsunuz toksikolojinin babası kabul ediliyor. Dolayısıyla Goldfrank'ı getirdik. Ona da bu ödülü takdim etmiş olduk. Ve sonra Paul Kivera aramızda. Ona da bu ödülü 2018 yılında takdim ettik. 2019'da Bingür Sönmez Hoca, yine bir kalp damar cerrahı, biliyorsunuz Türkiye'nin en tanınmış kalp damar cerrahlarından biriydi. Onu takdim ettik ve 2021'de Vincent de biliyorsunuz kritik bakımın kurucusu, dünyada gerçekten bu konuda lider olmuş bir bilim adamı. Ve şimdi en son ödülümüzü gerçekten kendisiyle burada olmaktan büyük gurur, büyük onur duyduğumuz, bakın basit bir şey değil. Futbol sahasında bir arrest görüyorsunuz değil mi? Genç insanların kalp durması sonucu ölmesini görüyorsunuz. Ve bu sendromu tanımlayarak dünyada birçok gencin hayatta kalmasına vesile olan büyük bir buluşun, büyük bir bilim adamını buraya getirmekten çok büyük onur duyduk. Ve bu ödülü kendisine takdim etmek bizim için hayatımızda onur duyacağımız, gurur duyacağımız bir an olacak. Bunu da mümkünse Zeynep Hocam'la birlikte verelim. Zeynep Hocam buraya gelin ve Joseph Burgada'yı buraya davet ediyorum ayakta alkışlarla. bir aile fotoğrafı için gelebilen herkesi buraya davet ediyoruz. Evet, gelebilen herkesi buraya davet ediyoruz. For next photo. Evet. Evet arkadaşlar, bir hatıra fotoğrafı Burugarda'yla gelebilen herkesi alalım. Evet, gel Halil.
Thank you very much. It's a big pleasure for me to be here in Antalya, and finally I could make it after the pandemic. 2-3 years that we could not make it, and I'm really very happy to be part of this meeting and to be with you today here. So we have this opening session, and it's a pleasure for me to introduce Salvatore Di Somma from Italy, that will talk about telemedicine for the future health system organization. Salvatore will make his presentation from Italy, I guess. Salvatore?
Yes, thank you so much. Can you hear me?
Yes, yes.
Thank you very much, Professor Brugada, and especially thank you to Professor Kander for the very kind invitation. Unfortunately, I have to apologize because for last minute personal issue, I was not able to come there, but really it's always a pleasure to be part of this really important international meeting on emergency medicine. My talk will be on the telemedicine for the future health system organization, and just I would like to share with you my conflict of interest since I am a part of this startup organization, innovations and technology in emergency medicine. That is the only problem that I have as conflict. Now, in my 15 minutes talk, I will try to demonstrate that technology and telemedicine will be of great utility in the future fighting with the acute disease. And in fact, from this paper from New England in July 2020 was very clear that from the COVID situation, pandemia, was really important to have this technology in order to monitor patients at home, but also at the end of the day, after this initial terrible pandemic, we got an opportunity, right? And in this paper is very clear how we can really see the possibility to also apply in the future with this technology, telemedicine, also in other diseases, especially acute disease. This is what we did in our institution, La Sapienza University in Rome, try to take people out of the emergency room, right? Because during the pandemic, I remember very well that many patients, they immediately came to the emergency room, but not all of them were really very serious to be admitted. So what we decided to organize this telemedicine concept with the patients that was selected by doctor based on some criteria of score of severity. And then there was a nurses station that was able 24 hours a day, 7 days a week to monitoring the patients with this smartphone. And this data were sent to a platform that the nurses was looking, and based on this criteria of a news alarms, if the data were green or yellow or red, some decision was be made. And this was be very fruitful in order to reduce inappropriate hospitalization in the emergency room, and also on the contrary, to admit the patients before they become very severe and need for ICU. But let's see now, how can we really try to implement in our daily practice in the emergency room utilization of telemedicine? You remember very well that during the pandemic, many patients with other acute diseases such as stroke or myocardial infarction or acute heart failure, they died at home because they were a little bit concerned to come in the hospital. But at the end of the day, we have to see now which are the consequences of the increase of many acute diseases coming and expecting in the future in the emergency room. Therefore, cardiovascular acute disease, both because of neglect during the pandemic and also because of the consequence of the COVID, we will have in next decades a lot of acute cardiovascular disease as a tail of the COVID that will come to the emergency room. So my question today is, should we apply telemedicine in fighting with this tsunami of patients coming in the emergency room with acute cardiovascular disease? You see from this paper from Nature Medicine just published a couple of months ago that heart failure patients will be really increased number need for admission emergency room because even in patients that the COVID without severe lung disease, there is an expected of an increased heart failure patients because, as you know, COVID-19 is not a lung disease, it's a vasculature disease. So I think at the end of the day, let's sit together, fighting with the most important reason to be admitted in the world, acute heart failure. How can we use telemedicine? I think this is just an example that definitely we can cooperate in the future in the network to see how can we really apply the experience of telemedicine in COVID, in acute disease in the emergency room. You know very well from this paper that we published as position paper of Association of Acute Cardiovascular Care, European Society of Cardiology, that first of all, we should distinguish between shortness of breath and when acute heart failure is suspected, we should definitely immediately approach in the emergency room by diuretics, oxygen, or nitrates, depending on what is the phenotype of the patient. I just want to remark that the job you do in the emergency room with acute cardiovascular disease always the most important one. I just want to take the opportunity to share with you this fantastic paper just published that in the emergency room with acute heart failure, we can have a best opportunity to immediately treat better the patients using not only furosemide, but adding acetazolamide, 500 milligram once daily IV is going to reduce the need for furosemide increase. Now, let's see how can we use telemedicine in try to reduce the burden of overcrowding in the emergency room with the patients with acute cardiovascular disease and especially with acute heart failure. In this position paper we published recently, it is very clear that what is important to immediately make a disposition, right? For acute heart failure patients, if the patient has cardiogenic shock or has acute pulmonary edema or is right ventricular failure, definitely you should admit to ICU. But you cannot admit all the patients. And now what is really important to see the possibility that you can send a team or nurses home patients from the emergency room. And this is coming the importance of telemedicine. In fact, this is the criteria that we pointed out in the European Society of Cardiology guidelines to see if there is this concept of a patient after staying in the emergency room, you don't need to admit if the patient has a heart rate below 100, systolic blood pressure greater than 100 millimeter mercury, but most important, if there is adequate diuresis, no signs of a congestion, you can send it to more patients. And here comes the application in daily practice for telemedicine. But first of all, I think that this paper from the Great Network we publish is very important to immediately in the emergency room adequately use ultrasound lung to evaluate the B-line and congestion. So all the patients that after treatment in the emergency room for acute heart failure should be decongested, you can really send it because these patients should be monitored in order to reduce the hospitalization. And this is the issue. Could we use telemedicine to send these patients at home from the emergency room and then check how is the status? I understand that this is really one case, but I was trying to make a scenario that is really something that we are expecting in the future. A number of patients with acute heart failure, how can we manage with telemedicine? And this is the project. You see again, nurses station, patients are selected based on criteria of score, and they receive at home a weighting system with bioimpedance, blood pressure, glucose testing, saturimetry for oxygen consumption, and then every day the patient is sending once a day at the nursing station the data, and the nurse is in contact with the physician in the emergency room. So the patients that are sent by the emergency room can be connected by the emergency room in order to see, I have to come back, I can stay at home. And this is what we did already in our preliminary 200 patients in Rome, where you can see having this monitoring, you can have a lot of information to decide, especially if there is no body water increase, if there is adequate diuresis, to take the patients at home and not into the hospital. I think this is a kind of, let's say, hospital at home that is also possible thanks to telemedicine. Once there is any issue in terms of the data, assuming that the patient has some symptoms, you can even organize from the, let's say, remote area, this telemedicine consultancy with the nurses taking the patients and with the remote you see the physician looking at the patients, and the patients can be explorated by also ultrasound or even natriuretic peptides, because we know very well that after the discharge from the emergency room, natriuretic peptides represent the most important parameters to control the stability of a patient, such as glucose for diabetes. And this also technology improving, because if you really want also to monitor these patients, you know very well that blood pressure in these patients should be an issue. So we have this special watch that we can use in order to better monitoring the patient. So we also need to familiarize with the patient's need in order to make the technology familiar with him. And this is probably the issue, right? Doctors should be thinking telemedicine as a solution to reducing overcrowding, but the technology should be also an issue for the patients. And even in the future, why not? Like they prepared recently in the UK to send at home even nurses and doctors to take patients at home, especially for let's say final situation and pay. So the final goal of telemedicine is putting people together, working in the interest of the patients and reducing the inappropriate burden in the hospital to move the health system from the hospital to the community when possible. And this will optimize the job of emergency physician that will only work with the severe patients and also for the hospital per se. Now, within the WASM, we really were able to point out in this paper after the COVID that you see many people from the WASM group that I'm honored to be part of, to show which are really the need for improving telemedicine program for emergency medicine. And at the end of the day, these are the most four important pillars that we have to realize in the future: patient safety and confidentiality, matrix analytics and reform, and this is also kind of institutional need, recording audiovisual data, and health record is very important to have the possibility that these data are going with the patient, with also electronic data, and also at the end of the day, lastly, the cost and the possibility to make this kind of activity reimbursed. At the end of the day, this is the last issue that just come out today, New England Journal of Medicine. There are also a lot of ethics issues that we should solve. First of all, the possibility of privacy, right? We should make sure that these data are utilized properly by the patients, and also we should really make possible, as much as possible, the future of improving telemedicine in conjunction with the patient's need. At the end of the day, I was trying to demonstrate that thanks to telemedicine, we can definitely manage acute disease outside the hospital, making a good connection from the emergency room, from the hospital, with the community. And I was taking the example of acute heart failure because we are expecting a lot of patients with acute heart failure as a consequence of the COVID-19. But at the end of the day, I just want to conclude my talk, just say everybody, especially young people in the audience, that always is very important also to have a clinical approach. So telemedicine is not a kind of alternative to clinical setting, it's a complementary opportunity. And if you are using this technology in many acute disease, I'm thinking acute cardiovascular disease, but also thinking sepsis, with the utility of biomarkers, definitely we can do a better job. I hope that this was a good opportunity to take some thinking on the people there. How can we really implement the future using telemedicine for reduce emergency room overcrowding and to give patients better healthcare delivery? Thank you very much from Rome and from my residents. Unfortunately, I was not able to come to that, but Bazar, you have to promise me that next year you will invite me again. Thank you very much.
Thank you very much, Salvatore, and please accept our condolences for you. This is in this time, and you can join us. It's very big honor for us. Thank you very much, Salvatore, and in next time we waiting you face to face, I hope, inshallah. Yes.
Thank you. Salvatore will have a discussion at the end all together with the three presentations. So now let me introduce Ariel Kibela, that will talk about the lessons learned from the pandemic.
Oh, can you hear me? Okay, perfect. Thank you, Dr. Kandar and Dr. Brugada. It's really an honor to be introduced by two of the most influential cardiologists and emergency physicians in the world, and it's a bit intimidating as well. Nevertheless, thank you for having me, and thank you for joining me today. I graduated in May from Pitzer College in Los Angeles, California, studying international politics and East Asian studies. I wrote my thesis comparing East Asian COVID response model to the United States. So that's what I'm going to be talking with y'all today. Oops. So while world leaders have called the coronavirus pandemic a once-in-a-century crisis, there is no reason to expect that to be true with climate change in an increasingly interconnected world. The only thing that is certain is that once this virus is vanished, another will take its place. Pandemics are inevitable. However, the systematic policy failures that accompany the spread of a virus are not. So if you look at this map, you can see that mortality rates due to COVID-19 have varied substantially across the world. In particular, there's a striking contrast between the Asia-Pacific region versus the United States. In particular, the East Asian tigers, which are Singapore, Hong Kong, Taiwan, and the Republic of Korea, have received universal praise for their ability to effectively respond to the pandemic. Given their close proximity to the outbreak and relatively low infection and death rates, are really a testament to the government's response to the virus. So let's talk about these governments and their difference to the United States. So the East Asian tigers are considered to be a developmental state, which means they're a welfare state. Because they were late to industrialize, they had to facilitate their own growth, which sometimes meant intervening in market failures and limiting individual rights to do so. The regulatory state is what the United States is considered to be, and that's not a welfare state. Regulating and rulemaking is more of a focus rather than providing. So basically, there are rules to prevent market failure, but there's not necessarily an intervention policy when market failure occurs. Also, they are not able to override politics in a time of crisis. So the East Asian tigers had a top-to-bottom approach. They started at institutions, and their institutions were made up of skilled technocrats and very educated elites. So these people made all the policies. Next, the institutions really partnered with had public-private partnership, which means they connected with their companies and invested in companies to get things done. This created a trusting society. So when it comes to pandemic preparation, COVID-19 is not the first epidemic that has spread through East Asia. SARS spread rapidly across the region in 2002. While the global death toll of SARS was much lower compared to COVID-19, the SARS outbreak inflicted huge GDP losses to the tigers. So after the virus hit, the governments realized they needed to invest and create a protocol for other public health crises. So they all decided to create an institution to step up in case of a virus. So if warning of an illness arises, it acts as an operational command point for direct communication among central, regional, and local authorities. These disease prevention agencies are particularly robust because they can override politics in a time of crisis. They also used H1N1 and MERS to really practice these crisis management techniques. Masks also became a norm during this time, and they used masks a lot during COVID-19. So when word came out that COVID-19 had been spreading, institutions issued strict travel controls. and this was not recommended by the World Health Organization at the time. They then used transparent and clear messaging to the public through apps and websites. They instituted school closures and mandated mask wearing and lockdowns. Next, these government institutions banned private companies from exporting masks and invested in companies to ramp up private mask making. They then worked with companies to produce test kits and contact tracing application apps. While the Tiger's response to COVID-19 demonstrates the importance of a strong institution and private partnership, they are all insufficient without public support. So in Asia, there's a strong culture of Confucianism and collectivism, and this really emphasizes the importance of protecting elders, social responsibility, and it had a strong sense of duty. A number of scholars point to these cultural responses to really explain the success of East Asian tigers. But I argue that focusing solely on this simplifies the picture of public trust in government. Moreover, citing cultural values as evidence of the success in these countries really excuses the United States' failures. So I argue that this collectivist and law-abiding citizenship can really be outproven, as these countries have a very strong sense of history and activism and opposition towards political authority. I believe that really it came down to public trust that was gained through the government's ability to appear credible, consistent, and transparent when providing information to the public. Moreover, in a number of these places, testing became mandatory. Isolation and quarantine was enforced with fines for people who did not adhere to the standards. There were also fines for people who did not comply with mask wearing. So the United States prevails as the #1 global leader in COVID-19 deaths. The American botched response to the virus really reveals the nation's insufficient preparation, divided leadership, delayed response, regulatory failures, and a lot of political posturing as well. So taking a look at institutional hurdles, the Center for Disease Control and Prevention, the CDC, and the US Food and Drug Administration, the FDA, made it illegal for private labs and even local public agencies to jump into action with their own solutions for test making. Instead of enlisting the private sector early on in the pandemic, like the East Asian tigers did, the US officials relied on test kits prepared by the CDC, and many of which proved faulty. So for at least 5 weeks, the United States had no idea where COVID-19 was. Another issue was that in the 10th Amendment, this made it impossible for the federal government to really have a national mandate that applied to every single state. So each state was kind of doing their own thing. Another issue was poor leadership. PREDICT, which is a research program for pandemics and epidemics, was disbanded and defunded during the presidential transition. And the Defense Production Act, which basically tells companies what to do in time of a crisis, was not used to its full potential. And also there was very unclear messaging to the public. So this obviously created a lot of public distrust. So if citizens do not trust their government, they're more likely to question or disobey government orders. Moreover, testing was not instituted was not mandatory, and it was on a voluntary basis. So whoever wanted to get tested could get tested, but they weren't telling people to go get tested. Moreover, there was no universal mask mandate, and contact tracing efforts were only instilled recently. So if you see here, this is some of the reason why the United States prevails at the top. for COVID-19 deaths. So quickly jumping over to vaccines, the United States was one of the first countries to develop a vaccine. However, this led to a lot of vaccine nationalisms. The United States basically hoarded a bunch of vaccines, and there was also a lot of vaccine hesitancy. So a lot of American citizens weren't very trusting in their government. On the contrary, East Asian tigers had a bit more of a difficult time getting access to the vaccine, and also due to geopolitical conflicts, they had another issue just getting the vaccine. However, they were still able to overcome hesitancy, unlike the United States. So looking at this map, or this graph, you can see that Singapore, South Korea, Hong Kong, and Taiwan really are at the top of vaccines and compared to the United States. So some ways that they were able to overcome hesitancy is they really trusted their health organization. They persuaded elderly to get vaccinated quickly. They fought fake news, and they made vaccines widely accessible. On the contrary, the United States, many people were wary of the safety of the vaccine. The vaccine became very political, became an argument of Democratic versus Republican sort of conflict, and there was a ton of social media misinformation. There was also an issue with racial concerns in many different groups. So thank you for listening to me today, and let me know if you have any questions later.
Thank you very much, Ariel. I think we will take question and the rest of discussion. Yes. And I want to invite the last speaker, Paul Kivala. He always part of our Intercontinental Congress. Welcome again, Paul Kivala, please.
Thank you, Dr. Kandar. It's always a pleasure and honor to be here in Turkey. This is definitely one of the best congresses that I attend every year, and I look forward to hopefully coming back and seeing you many times in the future as well. I'm going to be talking today about wearable technology in the emergency department and EMS, and this kind of goes a lot with the pandemic. It goes a lot with Dr. DeSoma's talk on telemedicine, because a lot of that has expanded very quickly over the last several years. My hospital does do something called mobile integrated health. And that's something where we use a lot of other providers to try to discharge patients home quickly, and oftentimes avoid admissions altogether. There's a program that our university is part of that has been at Johns Hopkins and Vanderbilt for many years, where it's called a hospital at home, where we'll discharge potentially 20% of the patients can be discharged to home rather than admitted. And we'll talk about the wearable technologies and things that are in there. I also have advised to several different technology firms, and a member of the American College of Emergency Physicians Innovations Committee, and also their task force looking at the future of emergency medicine. And I also work as a medical director of an ambulance company that's pretty innovative as well. What I want to talk to you about today is kind of the technology that's evolving very, very quickly. And one of the things that happens is we as emergency physicians don't really get any specific training on these things. And the changes are happening very quickly. And so I'm going to talk about some of the pros and cons of wearables, but I'm also going to talk about the different definitions, because what's a wearable? Do you know what a wearable is? Has anyone ever told you what a wearable was? Well, there's a lot of different things, and we'll talk about wearables. We'll talk about carryables, things that you can carry, and then we'll talk about portables. And all of this is something that is in addition to the various apps that are on your phone that could be a whole nother talk all by itself. Many of you are probably too young, and I'm not sure if Star Trek was a big thing here in Turkey. Was Star Trek a big thing? All right. So if any of you remember this, here was something that Bones McCoy carried around, and he was the doctor on there, but also Spock carried it around, and the Geo people. It was something called a tricorder. And it was this little handheld thing that you could basically diagnose a patient with. And so this was one of these really kind of futuristic things in the 1960s. Interestingly, in the US, there's a program called the X Project, where every several years they develop money to basically create a contest. And back in 2012 in the United States, it's a worldwide contest, they said, can someone develop the tricorder? And they went from 2012 to 2017. No one was fully able to develop all of the criteria that they asked for, but they've gone a long way. And over the next 10 or so minutes, I'll talk to you about some of the other ways that this is kind of advanced, and that maybe that tricorder is not so far off. So what I'm going to do is talk to you about several different things. And there's kind of 4 different definitions here I kind of talk to you about. Wearables are really something that patients wear. Dr. DeSoma talked about this earlier in the first lecture, and this is stuff of how you send the patient home. How do you monitor them at home? How do you monitor them remotely? The second is something which I'm calling a carryable. And this is something that the doctor, you, can carry on yourself to help diagnose patients. And these are changing very quickly as well. And there's also something that are called portables. And these are things that used to be large, like labs, like ultrasound machines, that are becoming very, very small, and that you can carry in your pocket or in a backpack or carry on a cart and actually deliver care bedside, where oftentimes this care used to be required. You draw blood, send it off to a laboratory that might be in another building, and your results might not come back for an hour or two. So a lot of this is changing very quickly, and there's obviously applications that are on your phone for pulse ox, for pulse, for rhythms. All of that exists right now. One of the things that's happened in the United States that Dr. DeSoma's talked about is happening in Italy is that there's now developing a payments strategy for wearables. And this is called remote patient monitoring.